I became involved in the field of medical interpretation and language access to a very tragic event in my life. When I was 14, my dad became very sick, and the whole family was literally seated in the waiting room of a hospital when a doctor and nurse approached us and asked if any one of us spoke English. My mom is a linguist. She speaks 7 languages fluently, including English. But at that very moment, she was so nervous and so stressed out that she reverted to her primary language only. So at the age of 14, I stood up and I said, I speak English. And the doctor proceeded to tell me that my dad had a terminal brain tumor and there was nothing they could do for him. Initially, I was just focused on how to communicate that devastating news. Wasn't really thinking about how devastating it was until my grandmother started wailing. And then I realized the gravity of the situation. She never looked at me quite the same after that. And I, rightfully so, no child should be the bearer of such sad news to their family. So I was 14 then. I said, I want to do something in the medical field. And when I met his nurse, it wasn't a hospice nurse back then because there were no hospices in 74, that I really said, gee, she does such gratifying work. And I really would like to add value, to be the same way. And then I became a nurse. So that's how I was introduced to the inequities of language access. But it wasn't until much later that I connected the two, because I was just still a 14-year-old, just trying to survive the loss of her dad. My mom was very young. She was left with 3 kids in a new country. We had only been here 2 years as immigrants. We had immigrated from South Africa. So that was where my journey started. And then it kept going down that line. So my first language, my parents are both from Portugal, and they immigrated to Angola, Africa, which it was a Portuguese colony. And I was actually born there. But at the age of 2, we moved to South Africa, where my sisters were born. So my first language, my mother tongue, is Portuguese. However, I would say that Afrikaans at that time became a very close second, because if you wanted to live in the community, you needed to know how to speak Afrikaans. My dad, though, always had the American dream, always. He always wanted us to come to the United States. He had a brother that lived here in New Bedford, Massachusetts, and he wanted his daughters to have an opportunity at a better life, to be able to go to college, and just to have things that he knew that perhaps living in other countries may not have afforded us at that time. So I learned Portuguese from my parents. I spoke Afrikaans with my friends. And then my dad, God rest his soul, I really did not like the man for this, but he made my sisters and I all take English. We all had to do our studies in English. So imagine a classroom of 15, 20 kids. They were all chatting in Afrikaans, doing their history in Afrikaans, and I'd be in the corner doing it in English. It was really trying for me. But once I came to the United States, they placed me in 5th grade. And we had done that work a couple of years before in South Africa. And I went across the street to the other high school, which was the junior high. And because of my ability to speak English fluently, I was not put into the bilingual program that they had at the time. And I was just mainstreamed, and I was able to get double promoted as a result of that. But I think that his vision of wanting to make sure that we didn't struggle as immigrants when we came here with the language, really is part of the reason, a big reason, as to why my acculturation to the United States was as easy as it was. I will tell you that when my mom and I get together, she'll sometimes, since everybody there speaks English and Portuguese, my mom will slip me something in Afrikaans. And I do understand it, but I don't speak it as much. I haven't spoken it literally since 1974. So, if you don't use it, you do lose it. Though I think if I went to go back, and spend some time there, it may come to me a lot easier than other people, because my first 12 years or 10 years of my life were literally surrounded by that language, the culture, and I was speaking it fluently. The challenges were interesting. You know, when you're doing something that you love, you don't always think about the fact that it's challenging, right? So I would say to me, I was very fortunate because I started off as being the only interpreter. So it was easy to manage. I managed myself. But then I ended up growing into overseeing 6 hospitals, then 17 hospitals, and then it grew to 42 hospitals across 11 states with a couple thousand physician practices. I was really fortunate enough to have great interpreter managers that worked with me. And I had 158 interpreters that I oversaw, had oversight with in the 11 states. Now, that being said, let me give you an interesting fact. Most of them were located in Massachusetts. Across the 9 hospitals, we were robustly staffed. We had a really, really mature interpreter program. And the only other hospital that I was able to implement with an interpreter on site was in Houston, Texas. And part of my goal was to be able to replicate that, prove that there was a need, prove the return on investment, and then have interpreter services at the other hospitals. But I left my job last May after 33 years of doing something that I absolutely loved. But I left it in May of my own volition because I really felt that I was getting to a point that I had done what I set forth in wanting to do. My goals were accomplished. The facility that I worked for really was wonderful in the sense that they gave me all the leeway to create what I needed to create. I was definitely not micromanaged. I was able to come up with every single job description that I had, except my nursing one, okay? My RN job description was the only one I was ever given. Everything else I ended up having to create myself. But again, the challenges arose when you have 9 hospitals in Massachusetts and you try to standardize the operations of interpreter services. That's challenging, but that's not impossible. Now you've got 42 hospitals in 11 states, only 1 with actual interpreters on site, and you've got to try to standardize the operations of interpreter services, mostly obviously through VRI and OPI for the out-of-state hospitals, and also agency interpreters. Standardizing things, making policies, educating people, making sure that they're aware of the regulations, Joint Commission, DMV, and yet being remote, even prior to COVID, is the most challenging thing. Because I think that one of my strengths that I've discovered is my ability to create relationships with people and to connect with people. It's a lot harder to try to connect with those people when you're doing it by phone or by video. So I would go on site. I did a lot of gap analysis for each of these hospitals to determine what was high risk for them, what was low risk in terms of disabilities, interpreter services, Section 1557, Joint Commission or DNV types of things, and also patient flow across the patient journey, making sure that we met the patient's needs at every aspect of their journey. Again, if you're boots on the ground, it's a lot easier because you can, in the moment, go down to registration and help them with something. Doing it by phone, scheduling meetings is a lot more challenging, but it's not impossible. So by the time I left, we all had standardized policies. We had standardized video, phone. That's the other thing I want to mention. Surround yourself with great partners for video and for phone and for in-person agency as well. These, you can get tons of vendors. Vendors you can find a bunch of, but truly finding the one that's going to be your partner is really what you need, because if you don't have that and you don't have somebody that's committed to your success, because your success means that they succeed and you're committed to theirs as well, then it becomes very, very challenging. So the most challenging thing for me was to roll out all of the equipment across 42 hospitals when most of them were out of state. But because of these partnerships with my vendors, it actually worked, and it worked great because they stepped up. They did a lot of the education. The other challenge is, I'm the type of person that would rather come and talk to you about why didn't you use the interpreter? And why would you think that that was okay, that that patient got less care or quality of care than this patient solely based on the language? It's much harder to have those conversations with doctors or nurses or administration remotely. So, but it also got me to thinking, right? So each state has different regulations and laws. So when I used to write up my policies, it'd be one standard policy, but then I'd have to have amendments because each state has different state laws. So you have to become very aware of the differences. You have to find the commonalities. And you also quickly realize that the cultures between Massachusetts and Louisiana, where I love going, or Texas, or Arizona, or Utah, are very different. So how to approach that, how to approach it with cultural humility, how to approach that in a respectful way, but not lose your North Star, because it's non-negotiable that human beings have the right to effective communication, no matter which state you're in, and no matter what the culture of the organization is. So I would say that my last challenge that left me black and blue, I mean, literally bruised, was when I was implementing Section 1557 in terms of the the bilingual clinical assessment. So in order to be able to assess bilingual clinical staff, in order to meet the requirements of Section 1557, we have to vet that the doctor who states that he speaks Arabic is truly fluent in Arabic in a clinical fashion. In other words, not just, I learned Spanish in college or high school with my broken Spanish and their broken English, we get by. Really, truly fluent in clinical Spanish, so that if they were to describe to a diabetic patient their A1C testing and results, and they spent 20 minutes with an English speaker, they should be able to do that same 20 minutes or equivalent in Spanish, versus what I used to hear. You have sugar in your blood. Stay away from sugar. It's bad for you. And that's what they could say in other languages. So as a result of that, many physicians and many nurses were really put out because they happened to be born to Portuguese parents. They learned from their vavós lap how to speak Portuguese or Spanish, or the abuelita, and they thought they were fluent. And I wasn't saying that they weren't fluent in Portuguese. What I was saying is that they weren't clinically fluent. And that's the difference. And about 40% of the people that took the assessment actually failed. So think about those 40% of clinicians being let out on the world, practicing their fluency that they think they're fluent on. So they're not even aware that they might not even be fluent. They think they're completely fluent in it. And what that really does to patient care and the outcomes that we're all seeking to address. So that was my most challenging. However, by the time I left, we had a very good program in place. We were probably ahead of some hospitals. And as you know, Section 1557 is, we're waiting for it to the last final ruling to come out. And that piece of it's not going to go away. It also helps all of these clinical people with liability, because there's an outside vendor that's doing nothing but assessing their clinical language skills. So if a patient claims that they took too much medicine because your Spanish was not good, you actually have something that says, no, but I passed with a 95. Right now, they had nothing. So that was the most challenging and perhaps the most rewarding, because I felt like I left patients and clinical staff in a better place. It's like asking me which of my children are my favorite. So Massachusetts is always going to have a permanent imprint in my heart because I spent most of my career here, all of my career really. And I literally started something that I was able to grow. And I felt like all of these wonderful people in Massachusetts had such great influence on my career, on my profession, on me as a person, allowing me to grow the way I did. I have to tell you that, in all honesty, I loved going to Arizona. I loved Utah. I was never fed as well as I went to Louisiana. The people there were remarkable. Down in Texas, I mean, it's such a vast state that I had the naive impression when I was traveling with a colleague that we could do all of our 5 hospitals like in one visit. We'll just stay there a week and then we'll go visit them all. But they're like 6 hours away, 8 hours away. So I think that there were certain components of each state that I loved the most. And when we used to travel to these states, we'd always make sure that we went where the people went. I'll give you an example. We went to Ohio and we got there early and we always stayed at Airbnbs because we wanted to stay in the neighborhoods, not at the hotels. We wanted to see more of what the community felt like. And there was an African American festival going on in Warren, Ohio. And Chris, my colleague, my dear friend, and I went. And it was mostly, I think maybe a handful of white people there, the two of us included. We got more data from that community than the gap analysis I did for that hospital. Okay. Because they were very, very pleased that we were there. We were asking the right questions. We were enjoying great food, great company. Several prayer groups were going on. So I think each Pennsylvania, the whole differences from the Amish to, Philadelphia, each state to me had its own little nuggets that I would like to cultivate. And then, of course, in all honesty, each state had some things that I would have loved to change in the sense of laws or not enough regulations about interpreter services, not enough regulations about LGBTQIA, So as you know, there's such intersectionality between people, right? I could be a Spanish-speaking woman whose race is Black, who is disabled, who identifies as gay, right? So you can't just treat that one little aspect of me. You got to treat me as the whole person, right? So I saw little things that could have been improved, but I have to say, all in all, what I find remarkable in healthcare, even under these conditions that we have had, that are very challenging and continue to be challenging and are going to get worse, unfortunately, before they stabilize, is that people genuinely want to do the right thing. I don't think that any doctor wakes up in the morning, stretches out of bed and says, I can't wait to tick off my first Spanish-speaking patient. They truly are not wired that way. Most of us go into the field because we want to help people. We want to serve others. And it's just becoming a little bit more challenging, creating a lot of burnout. And I think in some cases, obviously, having to work with an interpreter can add to that burnout, even if it's an unintended consequence. So I didn't answer your question because I can't choose my favorite child. On a personal note, even though it's professionally, it was something I did professionally. This is something that I'm extremely proud of. In the early 2000s, I was overseeing only 6 hospitals in Massachusetts for our system. And the managers and I would meet every month in person to talk about what obstacles they're running into, budget issues, operational issues, all sorts of issues. And the word got out about how much we benefited from that, almost like a support group. I hate to call it anything else, but it was like you're actually sitting with people that are doing what you do when you feel so isolated and often like you're the only one that understands it. You can't talk to interpreters. You can't talk to anybody else because they don't get it. And other hospitals started asking if they could join these meetings. And I didn't think that was appropriate because that was the business meetings for my hospital system. But in 2003, I started inviting managers from these other hospitals to come to this one meeting. And our first meeting had 22 different hospitals represented. And the expectation was that each one would bring something to share related to interpreter services, something that they had created, like a policy, a translation, whatever it was, kind of like a show and tell, okay? We even had a couple of vice presidents show up, and you could actually see people walking up to the table where I had all of the things that they were going to share. And we had to almost pry it out of their hands when they dropped it, because it's like they felt like they were sharing it with their competition. Well, that being said, after that meeting, it was quite evident that we needed to continue this type of meeting. This was the first meeting of Focus, and we have subsequently met every 2 months since then, since 2003. We would meet in person in Massachusetts for 3.5 hours every other month. People would drive from all over. Then people started driving and flying in from other states. So, it was remarkable. The first half hour, we would do like a little networking and we'd have lunch. And then the second 3 hours, or the 3 hours of the meeting, we would have presentations from each other. We would talk about issues. We would talk about Joint Commission, DNV, state regulations, et cetera, how best to handle staffing issues, how best to handle budget issues, how to even get interpreter requests, how to document. It was pretty phenomenal. And then COVID hit. And when COVID hit, it opened it up nationally. There was no reason, right? You don't have to worry about people driving, people, flying. There was no cost. And by the way, it's a no-cost membership. So now we have members from all over the country, and it keeps growing and keeps growing. Unfortunately, when I left my position last May, I could no longer be a member of Focus. So Focus is spelled FOCIS, not like focus like you normally would, because you have to be an active manager to be able to stay in Focus. So we didn't allow vendors in. We even got offered money to have vendors come do a presentation. We didn't allow people from the state in. In other words, they were welcome to come if we invited them to present on a certain issue. But it was really just a closed door meeting for us to be able to learn from one another, support one another, share policies, share job descriptions, you name it. So I know that collectively many positive changes have been made in individual hospitals as a result of all this information, resources, and support shared by so many people in Focus. So if anybody is interested in joining, the only requirement is that you have to be in some sort of supervisory capacity, whether it's VP, director, manager, coordinator, whatever the title is. And you can find the membership information on focusgroup.org. So that is FOCIS group.org. And I do hope that you will consider it, because it really is such a wonderful group, very caring, very, it was something that I created. And then before I left, I had removed myself from the board, and people would say to me, aren't you worried that, it won't be so robust and, maybe it will become defunct? Are you kidding me? Not with the people that I knew would take it to the next level. Right now, the president of the organization is Chris Kerwin, and the whole board and the whole group is doing fantastic. So I think it's inevitable that changes will occur. And remember, not so long ago, we were all concerned about technology, that technology would eventually replace interpreters. And here we are, we're still here, right? When remote interpreting came along, people were really scared that they were going to lose their jobs. There was a lot of resentment and a lot of resistance, right? Then 2020 hit and COVID-19 hit. And we all came together just to serve patients and honestly, simply to outlive the virus, right? And technology played a huge role in protecting people from unnecessary exposure to COVID. And in some cases, it even saved lives. I mean, in all honesty, I don't think we could have done it without our colleagues that were doing remote. And you've got to always remember that it may be a machine or technology piece in front of you, but behind that technology is who? Human interpreters doing a very difficult job. The numbers of limited English proficiency patients will continue to rise, which will create even a more demand for interpretation and translation services, right? And I think that people need to be aware that that's not going to change. People are going to continue to come to this country. Unfortunately, there'll be continued wars and refugees coming, and we need to be prepared to best serve them. The other thing that's important to know is telehealth. Telehealth really blew up during COVID, and it's become a very real thing and used by many. And even after the pandemic, it's here to stay, right? We will continue to provide a valuable service, especially in rural areas where specialists and behavioral health providers are very limited. I hear all the time of people in the Midwest sometimes having to travel 200 miles to see a specialist. So telehealth will help healthcare facilities who are also strained with lack of staffing to avoid being overwhelmed as well. And basically, face it, who doesn't have staffing shortages nowadays? So many people in the medical profession left as a result of COVID. LEP and deaf patients will always remain vulnerable. And therefore, I'm very happy to see, honestly, this is a very exciting time in our lives. I'm so happy to see the initiatives taken by Centers for Medicare Services, the HHS, Joint Commission, and also all these different states that are now mandating language access plans and to increase equity, right? I've never heard people talk about language as much as they're doing right now. Yesterday, I was on a webinar with the state of Massachusetts because they're doing a pay for performance tied into all sorts of race, ethnicity, language data, interpreter services, disability aids, SOGI data, everything. And I think that it's a perfect storm. Everybody's looking at it. Everybody is, insisting on things changing. And I think as you saw through COVID, it did matter where you lived. Your zip code did matter because it was often your zip code that was the result of you not making it. Your skin color did matter. Your immigration status mattered. Your disability status mattered. People were not treated very equitably. But the next challenge and opportunity, whichever way you see it, I see it as both, is AI, artificial intelligence, which will require us to be very prudent and set up some parameters about when to use it, how to use it, and why to use it in healthcare. I honestly feel that there's definitely a place for it and there's a need for it. But like any other powerful tool, if you don't know how to use it, it could be dangerous, right? So I think we just need to go into this with eyes wide open. And it will be yet another change to those of us that work in language access. But I don't see it as a change that's going to annihilate the profession. It's going to just be a different way of doing things, like we've had in the past with telehealth, with remote interpreting, with OPI, et cetera. So the piece of advice that I would give anybody that's going into this field is surround yourself with like-minded people, but also surround yourself with people that are not like-minded, because those are the people that are going to really stretch your learning zone. Become members of the National Council on Interpreting in Healthcare, or CHIA, or IMIA. I find that there's a certain complacency between some interpreters and translators in the sense that we've always had work that came our way in a way. So it's like, why do I have to invest in doing this, learning this, becoming nationally certified, et cetera? You have to invest in yourself because, we don't do cardiac surgery like we used to even a year ago. So interpreting does change. Language changes, as you know. So we need to just keep abreast of all of the changes and all of the quality improvements, because we want to be marketable. We want to do a great job for our patients, not just a good job, a great job. And in order to do that, you have to be knowledgeable. So, the people that used to say to me, well, I speak, Russian. And, in way back, we used to say, oh my gosh, they speak Russian and they have a pulse. They could be an interpreter, right? And now we don't do that anymore, right? Now, at least I hope we don't. I think in some cases it's still happening. But I think now people are aware that it's a skill-based profession, whether you're an interpreter, a translator, an American Sign Language, that comes with all sorts of nuances. But at the core of it is still being a human being, and having empathy for both the provider and the patient and their family, and taking care of yourself, because as they say, put the oxygen mask on you first, because if you don't, you can't do what you need to do. So self-care should be very important. Vicarious trauma is a real thing, folks, and people are experiencing it in our field. And I just think it's a great opportunity to do something you love, make a living at it, though we have to keep working on increasing the living wage, the wages for interpreters. But, I have no regrets in my career about that. I think the opportunities that some of my interpreters had were opportunities that they may not have had if it hadn't been for their language skill. I have to tell you, I probably have met Bruce in my life in person 3 times, maybe. The most I've ever spent with him in person, where it was him and I and maybe a couple of other people, is 45 minutes. So how do we have the chemistry that we have? And I honestly think we have this very genuine, authentic type of respectful friendship. And we like to banter with each other, and we don't always agree, but it doesn't change the outcome. If I call Bruce and I need anything, he's there, and the same way. And, this is another one of these wonderful benefits that this career has given me, is meeting people that I normally would not run into. I mean, Bruce is a pretty unique individual, and we're lucky that he's on our side of things, because he's a formidable person in his work, right? So I can't say to you how much I enjoy him. I love the panel. I don't know why I'm on a legal panel, because I'm not legal at all. In the sense of like, I'm legal, but I don't have any. I'm not a lawyer. I don't play one on TV. I'm not a nurse legal consultant. None of that. But I think the reason it works well is he sees it from the legal perspective. He sees it from academics, because he's a professor at several prestigious schools. And I think I have more of the inside knowledge, working day to day, keeping the lights on 24/7 in interpreter services. And as a result of my role, I also would get all the patient complaints, potential legal actions, et cetera, joint commission types of things that we needed to work on, DNV. So some of that's legal, right? And I always stay in tune to that, but it just seems to work. Come find out what Bruce and I are going to talk about this year, but I can absolutely guarantee you that artificial intelligence and Chat GPT and everything else is going to be part of it. I'm sure of it.